Perfect.
So
We
it sounded
hear you as well. So I'm going to go ahead and let's go ahead and Dr. Carey, over to you.
well. Good. Well, thank you, Terry, and we thank you again for orchestrating this. And I wish everyone a good afternoon or a good evening, depending on where you are in North America or some other place in the world. As I understood, we had perhaps some people coming in from other places. So for those that I don't know and haven't met, my name is John Carey. I'm basically a pediatrician who specialized in medical genetics after I trained in pediatrics and have had an interest in birth defects and related syndromes, including chromosome syndrome, since early in my career. This, as Terry mentioned, is the second in the series of our webinars, and we're already planning the third one for coming up sometime in June. So today what I would like to do is provide an overview of routine health care in children with trisomy 13. The purpose of my talk is to highlight and summarize the current recommendations for health supervision or maintenance in infants and children with trisomy 13. So here is an outline of my talk. After a very brief and concise background, some historical background, I will go through the known common and some uncommon manifestations and features in persons who have trisomy 13. And then I will provide you a brief overview of the principles that surround health supervision in individuals with syndromes in general, so that we can talk about trisomy 13 in particular. So first, a background. So trisomy 13, as I suspect everyone on the call knows, is the third most common of the autosomal trisomy syndromes. Autosomal, you may know, refers to chromosomes 1 through 22, the non-sex chromosomes. And of course, trisomy refers to 3 rather than the 2 chromosomes that we have paired. The trisomy 13 syndrome occurs in about 1 in 10,000 to 1 in 20,000 live-born infants. As again, many of you probably know, trisomy 13 also accounts for a chromosomal cause of some of our babies who are stillborn, which would increase this frequency. I think a figure of about 1 in 12,000 live-born infants is a good average kind of figure, and that happens to be the exact numbers in our state of Utah. Trisomy 13 is a known and recognizable pattern of medically significant and minor physical findings, along with an increased newborn and infant mortality and a significant psychomotor disability, which we won't talk about today in detail, but we will allude to. We say recognizable because the newborn doctors, the neonatologist or the pediatrician, often can recognize trisomy 13 in a baby at the time of birth. So here is the photograph of the original child seen by Dr. Klaus Patow and his colleagues at the University of Wisconsin in 1959 that led to the first paper. This paper was published in the British journal called Lancet in April of 1960, and it was a single case presentation of this baby. It turns out, interestingly, that the paper was back-to-back with the original Trisomy 18 paper by Dr. John Edwards and colleagues in the UK. But this paper came from Madison, Wisconsin, University of Wisconsin. Dr. Patel was a cell biologist working on chromosomes in the 1950s when the discovery that chromosomes form the basis of human conditions emerged. You can see this little friend here. You can see, even with eyes being closed, the presence of small eyes and the bilateral cleft. If we had the other pictures in this report, you would have seen that the infant also had an extra digit on the pinky side of hands and feet. And what was learned by Dr. Patel and colleagues was that when they looked at the chromosomes of this baby and of babies detected after that, that rather than having the usual number 2, there were in fact number 3. There were 3 of the chromosome that was called number 13. So in today's presentation, I'm not going to provide a detailed background of chromosomes in their biology. That, in fact, will be an upcoming webinar. But just to make sure we're all on the same page, let me just make a few comments. So this particular study depicted in the slide is of a boy. We know that because there's a Y. Chromosomes are taken usually from the blood. The cells are grown. The white blood cells are where they extract the chromosomes from, and then they take them from the cell and line them up in their pairs, basically from the largest to the smallest, with the number 1 at the top, our top left hand that you can see, and the smallest few, 21 and 22, down in almost the bottom right corner. When they originally determined chromosomes in the early 1960s, they put them in groups and they numbered them from 1 through 22 with the sex chromosomes. I'm not sure you can see my mouse, but if you can or cannot, the middle part of the chromosome, especially if you look at number 1, number 2, and number 3, forms a constriction that's called the centromere. The shorter arm around that centromere is called the P arm, and the longer arm is called the Q arm. So all of these chromosomes 1 through 22, again, are called the autosomes. We know that this extra chromosome material is the basis for the syndrome that Dr. Patel described, sometimes referred to as Patel syndrome, but we often don't really know how those extra genes cause the syndrome that we know so well. So again, just to make sure we're all on the same page about chromosomes, I just want to say a little bit more about the uniqueness of trisomy 13 and chromosome translocations, because it's really much more important in this discussion than it is in other chromosome syndromes, such as trisomy 18 or Down syndrome. So if you look at the 13, 14, 15, 21, and 22 together, they are called the acrocentric. That is, the centromere is toward the end. It's more distal, acro. You can just about tell the constriction on these chromosomes, especially you can tell it around the 13 and the 14. Well, it turns out that these 5 pairs of chromosomes like to hang out together in the cells, and chromosomes have a habit of breaking apart and getting together in between cell division. And so it turns out that the most common arrangement, normal arrangement of human chromosomes is when a rearrangement called a translocation between the 13 and 14 occur. And this common rearrangement, in fact, it's present in about 1 in 1,000 people, have a normal, balanced 13-14 translocation. You can imagine the frequency of people at a sporting event where there might be 50,000 people, most of them not knowing that they carry a 13-14 translocation. But it turns out that these acrocentric chromosomes hanging out together form a basis that's not understood, where there will be a breakage and reunion and forming of this chromosome that we see on the right, this dicentric chromosome that's made up of the 13 on the top and the 14 on the bottom. And you can see down in the right-hand column or right-hand side the actual pictures of chromosomes showing a 13, then a 13-14 dicentric chromosome, and then a normal 14. So this becomes important because rearrangements of the 13 and these other acrocentric chromosomes form the basis of almost 20% of trisomy 13, much higher chromosome arrangement, as I mentioned, in other syndromes. So we know from the population studies that have been done, and these figures on the right-hand column there are actually rounded out, but we know that in population studies that children with full or complete trisomy 13, that around 80%, 75 to 80%, will have a complete full extra chromosome. Sorry for that phone ringing. While about 15 to 20% will have a translocation rearrangement involving one of these acrocentric chromosomes, and the remaining percent, 5, will be accounted for by other partial trisomies of the 13 long arm or mosaicism. So that's just a brief primer on the uniqueness of the translocations of trisomy 13 because it plays such an important point in the genetics, and if there are questions about that, I'll take it at the time of questions. So there's our background. Original paper 1960 by Dr. Patel and colleagues. Original feeling for the syndrome pattern, and then the actual occurrence of an extra 13 chromosome. So let's spend a few moments on the features and physical findings and manifestations of trisomy 13. That is, the components, the individual features that allow the doctor or someone else to actually make the clinical diagnosis. So the phenotype, and that's the geneticist word for the physical pattern, the phenotype of this syndrome, that is the pattern, comprises cleft lip and palate, or more broadly, orofacial clefts, small or sometimes almost abnormal eyes, microphthalmia, you can see the word ophthalmia in there, micro, small, an extra digit of hands and or feet, polydactyly, extra digits, you can see the word dactyly there, on the pinky or fifth toe side, which is what the word postaxial means. So these three features, the clefts, the altered eyes, and the extra digits, are the most famous, sometimes called triad of trisomy 13. Turns out that no baby or child has all three of these in the triad. In fact, it turns out to be about 60% for each one. About 60 to 65% of infants and children with trisomy 13 will have a cleft of the lip or the palate or both. About 60 to 65% will have the more significant eye findings, and probably a higher percentage, 70%, will have the extra digits, always on the pinky or lateral side. In addition to that, children with and people with trisomy 13, just like people with Down syndrome, just like people with trisomy 18, have a certain set of facial characteristics that often allow the doctor or the clinician to make the diagnosis. The other important feature in this list of the phenotype is something I'm going to talk about on a separate slide in a moment, and that is the anomaly of brain development called holoprosencephaly. But I'm going to spend a minute or two extra on that. And it could have been put on this list, but I chose to put it actually on a separate slide. It's estimated that about 50 to 70% of children have that particular feature. So here's a baby from the medical literature who I don't know myself. I took this picture from a medical article showing an infant with trisomy 13 who does not have a cleft lip, and so you can get a better view of facial features that you don't get as well when a baby has one of the cleft lips that are so much more well known in the textbook pictures. And you can see the broadness of the tip of his nose, which is actually a clue in a baby who doesn't have cleft lip. You can see that this little guy also has a feeding tube. And also on the side view picture, see some minor variations of the ear, which will also sometimes tip off the doctor. The other important congenital malformations or congenital anomalies in infants and children with trisomy 13 include the presence of heart defects. About 80% of children with trisomy 13 will have a structural alteration of the heart, which does play a role in medical problems, especially infancy, but also in later childhood. Here you can see about 50 to 70%, depending on how the children are collected for the paper, whether they primarily involve children who have passed away or not, but about 50 to 70% of children will have this brain change I'll talk about, holoprosencephaly. You can break the words apart to help figure out the Greek there. Thirdly, many children, over 50%, will have, like of the heart, will have birth defects of the kidney. Fortunately, not usually causing medical problems, but potentially so, and requiring some screening. And lastly, a host of birth defects of the intestinal tract, omphalocele, which is the intestine out through the umbilical cord, being one of the more common, but there's a longer list that I didn't feel a need to go through. These are the more common of the important malformations. There's actually a longer list, but the individual changes are probably only 1 to 6 or 7% rather than this greater than 10% frequency. So let's spend a moment on this special finding of brain development that is so important in trisomy 13, holoprosencephaly. You can see again, you can break the word down, holo, which is single, prosen, which is the front part of the developing brain, and the cephaly is the Greek word cephalon for the brain. You can see that root, the root cephalon, microcephaly, encephalocele, and a lot of other medical terms that you may have run into. So holoprosencephaly is a serious change of brain development where the developing brain does not form the two separate hemispheres in the main part of the brain called the cortex. So it's not divided or cleaved properly. So it's really single. So rather than having two brain collecting chambers, the ventricles, there's a single ventricle, a holoventricle. And there's other alterations of the ventricle and other variations and changes of the brain itself, including the pituitary gland that's involved in hormones, and I won't go through them in detail. Many children with holoprosencephaly, whether they have trisomy 13 or not, because there are many other causes of holoprosencephaly besides trisomy 13, will have associated changes of facial structure. You may, if you've looked into this, you may have read about this, so that there are some children that have the serious problem where both of their eyes are fused together, or they really have eyes close together but have a single nostril rather than two nostrils, or often have a midline cleft right in the middle right below their nose, a very characteristic cleft of holoprosencephaly. I didn't attach any pictures, but so these associated facial signs are important. It turns out that among all children with holoprosencephaly, depending on which study you look at, 20 to 30% have trisomy 13. But there are many other causes of holoprosencephaly, including single genes, which we won't talk about today. But children with holoprosencephaly, especially the severe end, the lack of lobe end, the alobar end, have serious problems whether they have with breathing and survival, whether they have trisomy 13 or not. So holoprosencephaly, especially at the severe end of the form, the alobar or semilobar, cause problems independent of trisomy 13, and in fact probably play a major role in children with trisomy 13 as to who might have a more serious picture in the newborn period. And I'll talk a little bit more about that as we go along. But I wanted to discuss holoprosencephaly in a little bit more detail than other defects because it's so important in any discussion of trisomy 13. So here's my friend Aaron from Chicago. I followed many years at SOFT meetings. This black and white picture because Aaron's actually pictured in 2 textbooks of medical genetics in his walker. You can see many of you know older children with trisomy 13. Aaron is a great example. So I want to spend a few minutes now on the uniqueness of trisomy 13 and its sister condition, trisomy 18, among all other chromosome conditions, because I suspect that everyone on this call knows the rather unique and distinctive way that trisomy 13 and its sister condition, trisomy 18, are viewed often by obstetricians, newborn doctors, and the like. And both of the conditions share this increased occurrence of birth defects of organs, congenital malformations, especially of the heart, but as you know, others. They both share this increased neonatal and infant mortality, and they both share the somewhat similar developmental outcome of infants who are older than a few months or years of age. I'm not going to spend today talking about the infant mortality and neonatal figures. I wanted to spend more time on our major theme. I'm just identifying it as an important issue that, again, many know about. As Terry and I have discussed, I do plan to actually have eventually a webinar specifically on reviewing those figures for those that want to hear them in detail. But I just wanted to use this as kind of an introduction to the idea, the notion shared by, I suspect, everyone on the call, that the very often serious problems of health that occur in infants and newborns with trisomy 13 that make up the medical condition that we know. And this is where, again, where in trisomy 13, the holoprosencephaly ties in, because everything on this list that you now see occurs in holoprosencephaly of any baby, whether they have especially the more serious ends, whether they have trisomy 13 or not. So trisomy 13 in that way, again, I'm repeating myself, but it's just always important to play in that role that the holoprosencephaly might have. But important conditions that are related to the birth defects but are often separate is the occurrence of the central apnea, the issue where oftentimes the brain will not deliver the message to breathe, the other respiratory problems, whether they be in the upper airway around the voice box, the trachea, the windpipe, or even in the lungs, the associated feeding difficulties that prevent challenges, the high frequency of reflux that occurs in many of our children, but in particular in trisomy 13, and then the occurrence of seizures, which again in holoprosencephaly occurs whether trisomy 13 is present or not. So all of these findings here are what play into this role about problems in the newborn period, why the newborn doctors are particularly concerned at the time of birth, and play into how we're going to talk about routine health supervision. So I've already talked about this one. So here is my friend Aaron again. Now he's much older. This was at a soft picnic a few years ago, and this is just meant to have him be our poster child to divide us from the first half of the talk to the second half of the talk. And that is now I'd like to spend just a few moments, very brief overview of the principles of health supervision in syndromes in general, so we can lay the foundation for the meat and potatoes, if you will, of the recommendations for care. So it may seem obvious that doctors and health professionals would lay out principles of how we might routinely follow children with disabilities or not, but this idea of routine health supervision, preventive medicine, if you will, and regular guidance is only emerged in pediatrics in the last 2 decades, and primarily in children with syndromes in the last decade or so. But the American Academy of Pediatrics, that's the AAP, have nicely laid down something they call Bright Futures, which you can look at online, which lays out principles of immunizations and poison prevention and all the other guidance that ideally the pediatricians provide in well-child care. The point here is that myself and other specialists in genetics and pediatrics have tried to apply some of these same concepts to children with disabilities and syndromes. And in the 1990s, there were a few meetings at the American Society of Human Genetics, that's the ASHG, where actually there were some symposium held where some of these principles were laid out better. And one of the points that emerged was that in order for us to set down guidelines for health supervision and guidance, we had to really know something about the natural history, that is, the way a condition evolved, in order to be able to do that. And it was clear to me that even in Down syndrome and many of the other syndromes, including trisomy 13, there was really such little information on the knowledge and evolution about the condition over time. Despite that, some of my colleagues wrote 2 books on this topic over the last decade. Dr. Golden Wilson in Texas and Carl Cooley came out with 2 editions of Preventative Management of Children with Genetic Syndromes. They're not available online. They're still available on Amazon.com. And they really have checklists. And he actually ran his checklist by me for trisomy 18 and 13. A better book with more detail is the book by Dr. Cassidy and Dr. Allenson, now in its 3rd edition. And I wrote the chapter on trisomy 13 and 18 called Management of Genetic Syndromes, which is not just checklists, but really a very detailed text about this idea of health supervision. But let me tell you something about these principles just in a very brief way so that you have a foundation. The idea of developing principles for maintenance and guidance, where we'd have to have the accurate diagnosis of the child. Of course, that's not an issue in trisomy 13. We do the chromosome study, we make the diagnosis. But of course, if there's a partial trisomy 13, or if there's trisomy 13 mosaicism, we know less. There's the understanding of the natural history, which I was mentioning. That is, how do we collect good information about the frequency of these problems, especially that might occur, especially over time. What is referred to in medicine as the natural history of a condition. Obviously, we impact that natural history when we treat, but still natural history. The idea of developing screening, that is, screening approaches, so that once we know something about a manifestation in a condition, let's say holoprosencephaly, let's say hearing loss, let's say heart defects, we will develop ways in which we might screen for that to ensure better medical care. So developing guidelines for how we apply therapeutic interventions. Or for many conditions, let's say the use of growth hormone in a condition like Turner syndrome, we had to develop studies that actually showed that these therapeutic interventions worked. There aren't as many good examples, I'm sad to say, in trisomy 13, but again, I think the point is there. And then lastly, in terms of, and most importantly, in terms of health guidance and anticipatory guidance, the idea of the primary care physician and nurse practitioners and colleagues providing ongoing psychological support, feeling comfortable and confident in being able to follow an infant and a child, provide the medical home for that child, and also, if necessary, at least find the resources to provide genetic information and genetic counseling. So those are the principles that go into this idea that helped me in terms of laying out the recommendations I'm going to lay out in a moment. I think in the interest of time, I've kind of already said this, natural history, manifestations over time, so I'm going to just quickly go by these two slides because I've actually mentioned what was on them already. But just to close out most of this section, as I mentioned, the American Academy of Pediatrics has guidelines of bright future for all children, but they've also gone to the trouble of putting together a number of experts to develop guidelines for a number of other syndromes listed on this slide, and at the top, Down syndrome. They haven't developed guidelines as a group for trisomy 13, but of course that's what I've tried to do, and that's what's in this presentation. The advantage of all of these here are that they're actually consensus recommendations. They're not just one person. Today you're primarily getting mine with the help of other people. It'd be nice to have consensus. Maybe we will at some point in time. So let me spend our last few moments on recommendations on care that primarily are based on what we talked about in this outline, manifestations, and the overview. So just as background here, and this what's in this slide is actually the focus of my next professional viewpoint in the Soft Times that's coming out pretty soon. That is on trisomy 13, on older children with trisomy 13 that helped me think about these guidelines. Just for everyone here to know, there are still only 14 reported case papers in the medical literature of children with trisomy 13 over the age of 3, while there's actually 28 in the SOFT registry, and Therese Ann knows many, many more on living with trisomy 13. So just so you know, SOFT and living with trisomy 13 syndrome have a lot more information than doctors often have in their medical case reports. And everyone is, I hope, is familiar with the SOFT webpage where actually ability to register in Ann Barnes' registry is available. So let's talk a moment about medical complications of an outcome of older children, older infants and children with trisomy 13. So we've already talked about the heart defects present in about 8 of 10 children. Older children, like trisomy 18, do have a propensity to develop scoliosis. So this should be followed for by pediatricians, or if necessary, orthopedic surgeons as a child gets older. Many children with trisomy 13 will have difficulty with vision, even if they don't have the eye anomalies. So as you'll see in a moment, I will recommend, eye anomalies or not, regular visits to an eye doctor to make sure we're not missing any of the problems that can occur in more commonly than in other children with trisomy 13. Hearing loss. Many children will, even without a cleft lip, will have sensory neural hearing loss that is related to the nerve and the inner ear, excuse me, and thus should have routine screening. Excuse me, and of course, children have the developmental disability well known to the audience that would certainly warrants referral for early intervention and the appropriate rehabilitation programs. So the health supervision then would include referral for cardiac evaluation. Even in a child in infancy, I do think it's important to have heart defect evaluated so we know where we are, regardless of the intervention that a family and doctor team are undergoing. So I do think it's important to have that baseline and know where we are with the child's heart defect if it's present. Referral to early intervention, of course, is an axiom, but still important to be on the list. Follow-up on growth curves ideally should occur on the growth curves that were compiled by Bonnie Beatty that are present on the SOFT web page, including even the SOFT UK web page for Trisomy 13. The numbers are small, but I think they're better than having no syndrome-specific growth curves. Airway issues, especially in infancy, they can sort themselves out later, are often a problem, and it's important for referral for both airway and feeding on the next line to special clinics if that's what is necessary. 10 years ago, these special feeding clinics weren't as accessible in children's hospitals in North America, but they're becoming much more available. There now are clinics where children who have so-called, quotes, trach vent problems can go. In our hospital, Primary Children's, we call this our complex care clinic. As Terry mentioned in visiting me early on, that didn't even exist 7 years ago in our children's hospital. So as children get older, these problems may have sorted themselves out, but in a younger age, and you're helping families of younger children, often children's hospitals will have these complex care clinics available and take advantage of them if they are. They're becoming more and more an option. CNS imaging. It is my opinion that a child with trisomy 13 should have some imaging so we know, that might just be a sonogram, an ultrasound, so we know whether or not there is holoprosencephaly or not. I already mentioned audiology, I already mentioned ophthalmology, I already mentioned scoliosis and possible need for orthopedics. Lastly, I will mention palliative care team, and I'll put it in a question mark because the nature of palliative care teams in pediatrics, as a number of us have been discussing in recent months, is changing. Palliative care teams are not hospice teams. And the palliative care team that I'm connected here with at Primary Children's really is a support team for children with chronic disorders and not at all equated with a hospice team. So I think we're going to see a changing model about palliative care. And so just keep that in mind. I'm not making it as a recommendation, but just to keep it in mind as that evolves as a care model. So both these complex care clinics with airway caretakers and feeding and the evolving nature of palliative care teams are options for support in the future. So just some key references. Well, this paper that I wrote now, I'm afraid to say how many years ago it was about trisomy 21 and 18. It did provide those principles I told you about in the middle of the talk. A lot of what I talked about today on trisomy 13 is in the chapter on Cassidy and Allenson, which unfortunately is not available online, but I know many people have. And most of what I said today I also included in the 2 years ago in the Soft Times when Dr. Charita and I put this together. So I'm gonna stop at that point. I think I went a little bit longer than I thought, but we also got started a little bit later, and we still have, ideally, Terry, plenty of time for questions.
Very, very. I have a lot of he has them and working that. All right, we actually do have. Right, I'm going to start to have starting that. Let me see. Okay. I guess what are your thoughts on it?
Terry, I can't hear you.
You're not. Are you me at all now?
I'm sorry, I can hear the question from Christy here on my chat, but I can't actually hear you.
Go ahead. You can see. Go ahead and.
Okay. The call to osteopenia treatment. So full trisomy 13 services for you, maybe a year. So,
okay. I apologize. You're actually doing the same jumping in and out. And,
oh. I wonder, do you need to mute when I'm on?
I'm going to do that now, but let me go ahead and just go ahead and mute yourself, Dr. Carey. I just want to see if that's gonna clear it up while I'm talking. Go ahead and I'm going to unmute here in a second. And tell me, and if anybody down here in the chat wants to say how it's going. Okay, so now Dr. Carey is you're not muted. You're okay. All right, Dr. Carey, let's ask the first question, and if somebody can let me know if we're not hearing okay. That's because I want it on the recording. That's why. Let's see. This is from Christy Pollen. Our Sophie, age 9, with full trisomy 13, was on PrEP for 4 years, and we're wanting to know if that's an issue or a factor possibly for the osteopenia. Do you see any thoughts on that?
So I can hear you fine, Terry, there the last minute or so. So hopefully we're better now. So great question, because it appears, as I hear about individual children, that osteopenia, which means decreased density of bone, but at the below average range, toward the bottom of the range, while osteoporosis means that you're below what they refer to as their score of -2. So osteoporosis is more than -2 based on their scoring system. Osteopenia is more than -1. And bone densities that determine this are not as well established in children, but they're much better established now over the age of 5. And I keep hearing, Christy, about more and more children with trisomy 13 who get a bone density, where maybe having a fracture or two or not, and having osteoporosis or osteopenia. Maybe some of you know about those kids. So it may be that there is a higher frequency of osteopenia osteopenia and porosis in trisomy 13 that we didn't know about. I think it deserves study, because if it's real, maybe like one of the children I know, it does lead to a recurrent or change in fracture history, that we might be considering some of the treatment like bisphosphonates. I don't myself know whether Prevacid plays a role in osteopenia. It seems to me that I've heard that, but I don't know that off the top of my head.
Anybody else have any questions? We'll give just one moment here. See, I don't see anybody typing, so that's great. I know that I'm looking forward to the day, Dr. Carey, when we have to do an entire Q&A, because I know that there'll be lots of, actually, Chris is adding on that the daughter actually has had three hip fractures, and they're signed up for biophosphamide. I'm going to let you say that therapy.
Right. So what Christy has mentioned is that she has had 3 hip fractures in 2 years. And we're signed up for bisphosphonates therapy. And I do know that in one young man who has received bisphosphonates, I don't know if other people can see the chat, but it's spelled as it sounds, bisphosphonate. This is the class of drugs that basically increase bone density by decreasing bone breakdown. And we all know of more elderly people who are often on bisphosphonates because of osteoporosis, in women after menopause, in everyone after the age of 60, that bisphosphonates do work. In children where they have been used in brittle bone disease, osteogenesis imperfecta, they are administered with an IV, which makes it a lot more complicated than the oral medicines that are used in people in their 60s. For my own benefit, Christy, is she actually going to receive bisphosphonates by intravenous injection? Yes. So, and I think that if there has been a change in fracture pattern, like you said, 3 hip fractures in a short period of time, I would be supportive in her care, given her age, of consideration for IV therapy. Now, in brittle bone disease, osteogenesis imperfecta, we have a vast amount of experience. We obviously don't have a vast amount of experience in older children with trisomy 13, but I appreciate your doctors actually considering that and moving in that direction. So I think just like in the other boy I know, hopefully that will change her fracture pattern.
Thanks. Dr. Carey, what I'm going to do, I'm going to change our model here a little. I can edit, so that's the beauty of scissors. I'm going to have you read the question that's there. The big thing is I want to make sure the whole question gets read so that they hear what the answer you're answering. So if you've got them there, go ahead and starting with Barb Barlow's. I think if you go ahead and do that, that would be great. And then that way you can kind of keep.
And so I'm going to read Barb's question and then comment on and appreciate its significance. So the presence and absence of holoprosencephaly seems to be significant. Between TRICE and the data we have, I think we have a good potential sample of kids with full trisomy 13. It would be great to publish a paper on this one issue because I'm not sure providers are aware of its significance. Well, Barb, I completely agree, and I wish we had gone further with a paper, with a study that I started about 12 years ago, and I may have mentioned it to some in the past. So in 2000, I went to the SOFT registry and found that there were 17 children with trisomy 13 over the age of 3. And one of the neonatology genetic fellows working with me actually contacted all of the families. And we actually presented that information at a pediatric research meeting in 2001, but we never published it. Of note, none of the 17 children who were over the age of 3 had holoprosencephaly. Not all of them had imaging studies, but they had no other evidence to make us think they had the holoprosencephaly, which has led me to think that the absence of holoprosencephaly is a variable or a factor in improved survival in trisomy 13, because we were dealing with a group of children who were in fact over the age of 3. So I think that Barb is correct. From Bryce and Debbie Bruns has already collected some of this, and from other sources that Anne and others have collected, including Barb. I think it is a worthwhile series because we are ascertaining our group differently than the literature. And of course, the literature is completely biased toward collecting children who didn't survive. So while there's limitations in this way. So I completely agree, we should do this. The next question is, Natalia has frontal lobe fusion. Is that part of holoprosencephaly? They did say she was missing her corpus callosum, but then they said she was not. She does have frontal lobe fusion. So I suspect that the frontal lobe fusion is some part of the spectrum of holoprosencephaly, but it may fall in to the milder end that is called lobar, because alobar means complete fusion with a single ventricle. Semilobar means some fusion, some separation, the opposite way. While if there was some fusion of part, this may be the mildest end of the spectrum of holoprosencephaly. When they said that she was missing her corpus callosum, but then she was not, it might have been that when they looked at the CT scan or the MRI, not the ultrasound, because that wouldn't help you very much, when they looked at it, there was some corpus callosum, but it was thinner, and then when they did a better study, they could see that they're better than they thought. So it doesn't completely surprise me that they would say one time there was no corpus callosum, and another time there was, because maybe they got a better study.
And Dr. Carey, Therese actually added at the end, after that, that it was an ultrasound from the NICU, to how that was determined, or when they suspected that.
Right, and so thank you, Terry. So the ultrasound would not have viewed the corpus callosum very well to be able to clarify that for us, but I usually think that it could have made a distinction between alobar, no lobe, and lobar. I suspect that she has the mildest end of that spectrum, so-called lobar. So the next question from Rhonda is, are there any studies done that analyze the survival rate of trisomy 13 or 18 in children that have heart repairs? Well, interesting thank you for asking that question. So, because I'm actually been dealing with a number of emails in recent weeks and months about what are the data, what are the studies when you enter an intervention, and more specifically, heart surgery. Because probably many of you know, all of the mortality studies that we have come from the 1980s, 90s, and the last decade, when there was almost never inclusion of children who might have had more intervention, like can occur, and has occurred more and more in Japan. And we know that intervention while it does not, intervention of varying degrees, respiratory and cardiac, while it does not completely move survival to that of other children, it definitely improves survival. So the question is, are there any studies done that analyze survival in trisomy or 18 in children who have had heart repairs? So the best study comes from Japan in November of 2011 from the National Japanese Study, where they put together all the children having heart surgery with trisomy 13 and trisomy 18. And since I just looked at those data, they're relatively fresh on my mind. While the numbers are still, when you look at the children who only had heart surgery, we're only talking about 30 children. But survival in those who had heart surgery for a year or more was 50%. So survival with no heart surgery, just taking the numbers as they are, survival in trisomy 13 is about 5 to 10%, 1 year survival. In the Japanese study, based on smaller numbers, intervention plus heart surgery moves survival from around 5 to 8% to around 50%. So and the median age of heart surgery was 3 months. The original heart surgery studies done between 2007 and 2010, median time of heart surgery was later because people were kind of waiting and seeing what would happen. But the recent study from Japan, published in 2011, would suggest, still based on relatively small numbers, that heart surgery performed in the first few months in Japan, all other factors ignored in the discussion, would increase survival. Important question, because it continues to be an ongoing discussion. And in the two recent reviews that I wrote, one on 13 and 18, published last December in a current opinion in pediatrics, and the other one only on trisomy 18, didn't summarize all these data as now they could be summarized.
Thank you, Dr. Carey. And we actually, if we go back to Therese, I'm just going to go back and add in, she had one comment on it. When she says, talking about her daughter, about the frontal lobe fusion, you get visually, her forehead looks squished as she's saying it, and just wants to make that comment, if you have any comments about that.
Say the last part again, Terry.
We're going actually back to Therese.
Yes.
Okay, and she's saying that that with her daughter, that when she says frontal lobe fusion, actually you can see it visually when you look at her. Her forehead looks squished, is what she's saying.
Right.
So is that what you were referring to, or what you were describing?
So usually, I mean, there are two things that can occur in trisomy 13. Sometimes you can have, as a physical feature, kind of like nasal structure, a very narrowed forehead. That's usually related to the suture in the front part of the skull, not related to the brain underneath. So it could be that there are two things there. But maybe Teresa Ann and we could talk about that offline together in email, so I can help clarify that for her.
That sounds great, but that's interesting. That's great information. Okay, and so going back here, I want to go back. Barb Pearl is sharing that Annie, Keith, and Barb are working on a paper on outcomes for trisomy 13 and 18 and presenting a poster at PAS next week. Keith calculated the odds ratios from multiple regression analysis. The data shows that interventions are effective and the odds of coming home from the hospital was 7 times greater if the child had no prenatal diagnosis. What are your thoughts on that? Because I know I've been involved in several conversations about that type of thing lately, and I'm just wondering. Go ahead, Doc. Okay.
Right. So again, Barb, thank you. So first, I wish I was going to Boston. I'm sorry, Washington, for the Pediatric Academic Societies, but just like last year, I'm not able to go this year. And so I wish I was going, but I'm not. That is very cool. So um, Keith calculated odds ratios for multiple regression. The data show that interventions are effective. Great. And needs, of course, to be published as well. And the odds of coming home from the hospital were 7 times greater if the child had no prenatal diagnosis. And Barb may know that that's also similar to what Dr. Kosho showed in Japan. Although his work was probably, it may be a more biased sample than what Annie and Barb and Keith have. I don't know. But that idea that maybe the children that don't have prenatal diagnosis, that then are born, maybe have better survival, possibly because they're a different group of children. Anyway, is an issue that really needs to be explored. And so that would be my comment at this point, and I want to look at that information. I think we have to ponder it continuously. I mean, it could be that, and I don't know all the numbers, Barb and everybody else. I'd have to look at the numbers, and I don't want to misquote Dr. Kosho's paper, but it could be that the children who don't have prenatal diagnosis have different presentations in utero, and that's why they weren't picked up, although given how frequently we pick up trisomy 13 now, that doesn't quite fit. So I'm just thinking on my feet, and that they're a different group. We just have to look at that and ponder that more. See the next question from Therese Ann.
Actually, I think the next was just a wrap up on the going back to the heart repair for Rhonda, just based on your experience.
Right. So the question was, from your experience.
You're just getting, because you've met more of them and you've met more numbers.
So
how much does heart repair impact long-term survival?
So from my own experience, I have individual children that I know exclusively from SOFT, and I could give numerous examples, who had heart surgery during the first 6 months of life, were now actually living past that 1 year landmark. And those are just like, little pieces of a puzzle, individual, what we call them, case reports or case series. I think that's one set of knowledge, but from my experience then, I think it does make a difference. What I like to fall back on more, even though the numbers are small, are the data from Japan, because it's in fact what the doctors will often believe even more than my experience, because they'll have published studies. I just sent an email to a doctor yesterday that he thanked me for, where I summarized the Japanese data as as well as other studies in a decision that they were trying to make, and then he wrote me back, thanked me because that helped him at least sort it out. So the one reason why I tend to go with the studies more than my experience is the doctors will have a tendency to trust it more.
Exactly. We understand that, and we appreciate your distinction there, and we also like, in addition to hearing your distinction there, we do like hearing your opinion. So anyway, that being said, I'm going to go ahead and I know Trisomy is adding in, and I think this is a really important thing for us to have to talk a little bit about, and although she didn't really phrase it in the form of a question, I know you referred to it, but I kind of am going to say what she said, and then maybe I'll change it into a question a little bit. Is, having, I know in her daughter's case, she had G-tube surgery, fundoplication surgery that helped with GI issues. The G-tube actually was at six weeks, and a fundo by the year. And I know, of course, my daughter has trisomy 18. We gave the G-tube at 6 months. What are you seeing as you're out there as far as not, I won't say a trend, but as far as you're obviously nutrition helps the child survive, but as far as thriving and that sort of thing, and moving on with their development and growth, where are you seeing as far as the number of kids that are actually G-tubes versus not, that sort of thing? Any comments or thoughts on that, Dr.
We'll certainly, people are putting in G-tubes, gastrostomy tubes, and better methods they have now, much more now than they used to. And just in my own experience of going to soft meetings for 25 years, I don't think there's any question that they're helping and improving all aspects of care. I think one thing that's different about children with trisomy 13 is that sometimes, even though all of us, we know that we want to try to be able to treat physiologically if we can, but we often can't. So the G-tubes really do the job. My overall experience of now compared to 25 years ago is night and day for improvement.
Awesome. That's really exciting to hear. And just as a mom, and my first thing with knowing and seeing the issues with feeding issues with Christina, well, first of all, when the question came up about feeding and G-tube and that sort of thing, even before she was born, my first comment on it was, well, as far as I'm concerned, this is the full meal deal life. So whatever it takes for you to get your full meal deal in, that's what we'll do. And then the second thing with Christina was that, it first broke my heart. My biggest hardest part, our feeding issues with Christina, was that my heart was broken at the thought that she might never have a chocolate chip cookie. And then I realized instead that didn't interest her, and instead we put our interest and her energy into growing and working on the things she was interested in, rather than taking all the time to work on her feeding, because we were using as much energy to get the food into her that we needed to start eating again as soon as we were done. So that, I'm just adding that in as a parent using it. So I know for us, it's just been a godsend, and it's just great for her. So I don't see any other questions. Let's see, we do have another one coming in. Great, I like this. And Dr. Carey, are you doing okay for a few more minutes for time?
Yes.
We'll take like this last question, and then we'll wrap it up. And we have a lot we can put out, so it won't be that long online. What is Dr. Carey, what is your opinion on apnea resolution the older the child gets? I have a 78-day-old full trisomy 13 baby girl named Nora who's doing extremely well since discharged from the hospital. She's been 10 days in the NICU. Atlanta, Georgia, brand new to the group, and you're so glad you joined us today, Sarah. Go ahead, Dr. Carey.
Yes, I think that not having that apnea, that central apnea, where the message to breathe doesn't come from the brain, not having that symptom in the first few weeks of life says a lot. I wish it meant that it would never could occur again. But the fact that Nora is 78 days of age and has not had central apnea really says a lot in her favor for the absence of that symptom compared to the average child. I mean, as we know, most of the children who don't make it during the first few months of life don't make it during the first few weeks of life. So just being at 78 days actually says a lot. In some ways, because Nora's doing so much better, just on average, she's in a position where I think her doctor might want to sort of make sure she's getting he or she's getting a good handle on how she's doing. Can she protect her airway? Are there any other respiratory symptoms? Because you said she was doing so well otherwise. So it'd be nice to have that confirmed and not have any surprises. But I would say that says a lot that she's 78. I wish that meant it would guarantee everything else, because while we know how crucial those first few weeks are in declaration, where someone is, trisomy 13 is still a serious condition in other ways, and there's so much more fragility we can't always often predict. That's why I like that idea of hopefully her doctors are kind of regrouping and saying, oh, she's not typical for a baby with trisomy 13. We better keep our eyes open here. See what I mean? I hope that made sense.
Absolutely made sense. Dr. Perry, Sarah's gone ahead and added that she has a CHF well controlled on a small dose of Lasix and is on no other medication. So, um, kind of gets a little more of a picture of how she is, and we're excited. And what I'm going to do, we're going to go ahead and wrap up, but this leads really me into Dr. Carey. Thank you so much for your time today. As a mom of a child with a trach that was trached at 3.5 months due to obstructive apnea, I know that whole topic leads me to just so many questions. My brain started to explode, and all the things we can explore. And so I'm going to go ahead and cut us off now for questions, and appreciate everybody's time this evening. Dr. Carey, thank you so much for your time, this wealth of information that you provide with, focusing specifically, of course, tonight on trisomy 13. But I know that the topics just are endless that we could focus on. So thank you so much for your time, and for just for knowing that you're going to continue this journey with us, and actually I believe in every case here, having been there, already there waiting for us when we showed up with our kids. So thank you so much. Appreciate your time. Any last thoughts that you want to share before we say goodbye?
No, just to thank you, Terry, for orchestrating this whole series. I think it's I actually have enjoyed all the questions and helping to refine some of these areas that we don't have the answers in. So I appreciate the questions from everyone.
Our relationship with SOF is going to be all about. And so thank you to everyone for joining us this evening. Next week, we're going to be doing actually a webinar. It's going to be trisomy moms. We're going to be sharing some tips and tricks on getting your child moving, because one thing we do know is one issue that we deal with a lot is constipation with our kids. It's either all or nothing. At least that's where it was for us for a long time. So come back next week. Go to trisomytalk.com or find us on Facebook, and you can see when that's scheduled for. And appreciate again. We'll get this up online as quickly as we can. Share it, get it out there, because here's what we know is that if there's hope, there is hope. We need to let people know that. Welcome again. Thanks, everybody. Good night.